Hi, good afternoon, everyone. This is Sabine von Price-Friedman from our Drive to Deep Prescribe. We're going to give it a few seconds so that everybody can get in from the waiting room, and then we will start. I'm just going to monitor if there's more people entering, and I think we can get going. So today, the week after we had our AMDA meeting, those of you who were there, I hope you shared our excitement at seeing each other again, that you took many important impulses from this meeting. For me, it was an absolute pleasure to meet Dr. Cheryl Hawkins, who is going to be our discussant today. And I'm really looking forward to what she has to say. And I also felt like the meeting was sort of the meeting of the pharmacists. I think we had wonderful highlights of successful collaborations with pharmacists that drove back best practices, including deep prescribing. And Dr. Hawkins' team also had a success there. But of course, we had the Clinician of the Year being a pharmacist, and the poster winner being a pharmacist, and then Dr. Hawkins' team also had a success. So we'll dive right into a discussion of the first person in the Spearhead group, and that's Dr. Cheryl Hawkins. Before we do that, let me tell you just kind of where we were and where we are. Last week, we had just a wonderful webinar by Dr. Leah Watson about optimizing use of dementia medications, looking at side effects and drug interaction of choline esterase inhibitors and memantine. And we gave you a tool, a choline esterase inhibitor and memantine deprescribing algorithm. You can, if you haven't had a chance to see that, you can get that on our landing page. I think it just was a wonderfully informed, but also human and empathetic discussion on how to optimize medications for our demented patients. Before then, we've done PPI. We've gone through quite a few. We're not done yet, but we've gone through quite a few. We've done PPI, we have done MVIs, anti-hyperglycemics, anticholinergics, and benzos and other anxiolytics. And last time, when we started the webinar, we had just gotten this particular email. And this email came from Dr. Cheryl Hawkins, and she wanted to share her success using care conferences as a time to educate families and review medications. And I gave you a little glimpse, but when I was done with the webinar, I was just thinking, this little email could be a whole hour of discussion and webinar, and Dr. Hawkins was kind enough to join us today. So welcome. You know the drill. This is our All Teach, All Learn session. In general, we want you to participate. I'm really looking forward to hearing your comments on what this Spearhead nursing home has to share for us. And I also want to hear your frustrations, and I want all of us to chime in and maybe help those of us who are not getting where we want to go. So please make extensive use of the chat. We will be monitoring that and pulling that into our discussion. So our presentation today is D2D A Journey. Cheryl Hawkins is the corporate medical director of Evangelical Homes of Michigan, but she's also co-medical director of EHM Senior Solutions Nursing Home. She joins us today, but even almost more importantly, we are joined by a team member of Dr. Hawkins, who has really been a stalwart in really been driving deep prescribing in her facility also, and that's Chrissy Parra, RN. She is the assistant director of nursing, so she is the team champion. Tell me if that's not true, but she's probably the facility champion. We always talk about how we need a facility champion. Ms. Parra has been a nurse for 20 years. She initially worked in the Army, and she has been with the facility for a very long time, I think over 10 years as well. So these people like you, Chrissy, are the ones that we as physicians and medical directors and family members so rely on. So I'm really looking forward to your presentation. So Dr. Hawkins, please go ahead. What I didn't say about Dr. Hawkins, which is really cool, Dr. Hawkins has worked internationally and has also established a care home for the elderly, I think in the Philippines, and you worked in Kabul as well. So really fascinating, but that's probably another webinar. But let's just go ahead and tell us where you work, what challenges you faced, and how you made it all happen. To you. And tell me when you want to advance slides.
Thank you, Sabine. I really appreciate the opportunity to share our story, and it is a story. Let me set the stage. Saline Evangelical Home of Michigan is a 150-bed extended care facility with 50 subacute beds. It's outside of Ann Arbor, Michigan, a rural area with some subdivisions. Historically, the time setting is spring of last year, and we were just all done with COVID. We were just exhausted and still struggling. We had staffing challenges. We had leadership roles that were unfilled. We've actually had now 6 administrators since last spring. Oh my gosh. We've had 9 infection control specialists in the last 2 years. We had 2 social workers resign. Our ADON position was empty for about 9 months. And so, next slide. We really didn't have anybody at the facility who could commit any more time or energy. And I remember last spring when this whole thing started, somebody was on our phone call that said she was the only one as part of their D2D team. And I sort of felt the same, but tried to figure out how can we move forward. This is the opportunity to do this if ever there was one. And so we built a team with non-facility personnel to start with. Our consultant pharmacist was all in on this. He was a person who really was passionate about deprescribing. I figured a hospice nurse who's not part of the facility but comes regularly would at least know our culture, our systems and processes. And she's there 2 times a week at least. And then our nurse practitioner provider, Lori Feiner, who is there in the building 2 to 3 times a week from the University of Michigan. So
this is really extraordinary that you incorporated a hospice nurse in the beginning just to get a team going. Congratulations for thinking about that.
Well, thank you. We needed to have nursing somehow involved. And although it's not a facility nurse, she does review the meds. And I mean, that's what hospice nurses do at the start of care. So while we were gathering our initial dashboard information for our baseline, we started to set up a process of how we were going to review the hospice patients' medications and make changes. Next slide. As we had our first couple meetings, we realized that we can't do this in a vacuum as a small group that's outside of really the facility leadership. We had to spread the word. We had to educate. So we sent letters to the families describing this whole medication optimization program. And there's a copy of the letter, I think, right after this slide. Yes, and we also sent flyers to all the nurses, which briefly showed the benefits of deprescribing. So if a family member said, hey, I heard you're doing this, I'd like to talk about, they wouldn't put them off, they would know something about the process. And we focused on what was important for them. Reduced medication pass time, fewer falls, fewer send-outs to the ER. And then in September last fall, we did a family information meeting. First with a general talk about what is deprescribing actually and what are the benefits to it. And then we got into the multiple vitamins and the PPIs, which we'd already learned about. And this was done by myself and the consulting pharmacist.
May I ask you a question? May I ask you a question? I don't want to interrupt, but I'm really interested. First of all, how did you send the family letter? Because this was in 2021. You were still somewhat shut down. Did you send it by mail or email? Or how did you do that actually?
Chrissy, do you know? I know you weren't in that role then, but.
Yes, it's sent by email. We have a nice chain email setup system. There's a few that aren't. So those 6 we send by.
Okay. And okay, so that's good to know, because that snail mail may be a little bit more cumbersome and time consuming. Mm-hmm. And then at the family orientation setting, how did family members react? And was it a Zoom meeting, or how did you do that?
No, this was in person. It happened to be at a time when, I think, before Delta came through.
Yeah.
So we were able to open our professional office building that has a conference room and hold it. I think we had about 12 to 15 family members there. And a few nurses came interested. Let me go to the next slide and we can show you the letters and flyers that we sent out. So this is the one for the frontline staff to describe the benefits. I know the writing's a little small. And then there should be another one that has the letter to the family.
I really like this. I think this is one of the slides from one of the D2D, from one of the D2D presentation. So brings it to the point, and really it's very short. I like that. And gives the benefits. I think it's quite brilliant. This is the family letter here.
And so there's both a letter and then another flyer for the family to say, if you have concerns about medications, please bring it up with their nurse, their doctor, or at their care conference. Chrissy, did you hear any feedback at that time from families getting that? Again, you weren't in your current role, but I'm curious.
I did not.
Okay. Next slide. In October, we had geriatric fellows that come over twice a month approach us to say, we're looking for research projects we need to do to complete our fellowship. We said, come on, join our team. One decided to work on anticholinergic reduction, and another one chose to work on reducing sliding scale insulin. And then, thankfully, in November, Chrissy came out of MDS and became our ADON. Next slide. The workload for all our team members was this. Each team member watched the monthly D2D webinar on their own. And then once a month, about 2 weeks later, we had a team Zoom meeting for about 15 to 20 minutes. Nothing long. So, yeah, please go ahead. The process for our first project, the hospice process, was that normally the hospice nurse looks at the meds and makes a recommendation to the provider, and then meds get reduced. But we notice that there still are an awful lot of meds on hospice patients that really aren't always focused on their comfort and their best quality of life. And so in this process, once a patient signed on to hospice, our hospice nurse immediately sent that name to our consultant pharmacist, who looked over the list and made suggestions. And that went then to the provider. And the three of them together made recommendations that the hospice nurse would then talk with the family about. Since starting that process last spring, we have had a 23% reduction in the total number of meds per hospice patient up till this February. So it did make a difference.
I say that is fantastic. As you may recall, I didn't bring it up this afternoon again. Our goal was 25% reductions. So you were like with your hospice patients right on the money almost. So this is really fantastic just for the hospice. And I wanted to tell you that There is so much chat in the chat right now about those letters that you sent, and everybody wants a copy. And we'll certainly thank you for making that available to us, and we'll certainly we'll make that available to all of the D2D members.
Yeah, a lot of that came out of the D2D resources that you shared with us. So we just tweaked it to have our name on it or adjust it to our data, but
Cheryl, Sabina, if I may ask a couple questions. So, you have totally left me already energized. I know you're not done yet, but just to hear that AMDA's campaign was really that helpful to energize a team. And not that, you needed, again, we've always said that we're just cheerleaders. We're not sharing any rocket science strategies here. Just to hear that, the national AMDA D2D campaign was helpful to for a team amongst a pandemic to come together, have a bigger purpose and be able to pull this off just kind of leaves me so energized already. So thank you for sharing your story. And the second question I have is, do you have an idea what were the main categories around those hospice patients specifically? Because that's so intriguing. I never thought that this could just be a game changer for hospice patients. Of course, we think it could be a game changer for anyone, but do you, by the top of your head, know what were those main categories of medications?
Multiple vitamins, PPIs. There were a lot of PRN anxiolytics or benzos on there that weren't being used, a 60-day non-use. And we got rid of those. So it wasn't there's still a lot of work that can be done, I think, in that population. We still have, I think, an average of 10 or 11 drugs per person, but it was not difficult or hard to convince people of. It was just looking at it, spending the time, and using the resources we had with the consultant pharmacist to kind of make the lead. Let's think about these.
Yeah, it's not rocket science, it's effort.
Yeah, it's taking a little nugget of energy and using that as a nidus and then coming together around it and snowballing it into something really big. Man, this is a phenomenal story.
Our next process was our care conference initiative. And I'm going to have Chrissy talk to us about this. Take it away.
All right. Brainstorming with the team, I had the idea that care conferences would be a good time.
Sorry to interrupt. I would really love to know a little bit about your background quickly. I know that you're an assistant DON, but can you tell us a little bit more about yourself and how long you've been with the facility, how long you've been in long-term care, and how come you're so passionate about this? Just a couple lines about that would be helpful.
Yeah. I've been a nurse for 20 years, started in the military, in the Army. I've been at this facility for 18 years. I've always loved long-term care. I did a rotation at the VA hospital when I was younger, and I really loved working with the elderly. So I've been here for all this time. I've worked on the floor as a charge nurse and in MDS for 12 years. And now I've been doing the role of ADON.
Wow. Thank you so much. Thank you.
Yes. Yeah.
Excuse me, Chrissy, I think of MDS as another resource for you. I think they know a lot about your facility and sometimes might be able to assist.
Yep.
MDS nurses are smart. They have to be. All nurses are smart, but they really are very organized usually.
Yeah. Yes, I definitely am. I pride myself on organization. But had the idea that care conferences would be a good time to talk to families, and it wouldn't be so overwhelming for the staff. We have about 6 care conferences a week, and in the course of 9 days, we could then see all the long-term care residents. So at the start of the week, I print out the med list for each patient, and I put them on our nurse practitioner's desk in a folder. When she has time, she goes through them. It takes her about 15 minutes, and then she brings it back to me. I disperse them to the unit managers, and they take them to care conference and go over the medications with the family, and the NP puts notes next to it too of the whys. We have found some areas for improvement. We have one unit manager who's got 100% almost compliance. and then another one with 25%. So Dr. Hawkins does have a meeting set up with the unit managers tomorrow and myself. And we're going to go over what has been useful for the unit manager who is having such success. Previously, as to starting this, I wasn't having them come back to me. I wasn't tracking the data. So going forward, I'm going to, so we can understand better how this is working.
Chrissy, quick question for you. How much family pushback did you get? So many times, I'm in AL primarily, but so many times the family says, oh, but mom's been on that for 20 years. We can't take that away from her. How much pushback did you get from the families?
There is some pushback. And the one unit manager I spoke to, she says, you know, they're concerned and they want to talk further with the doctor. They don't really know that they want to take them off. And so I wish she had brought that back to me, because then I would have had the nurse practitioner reach out to the family. So going forward, that's something we're going to do.
Well, and we would include a paper that was just published in Journal of American Geriatric Society last week, or I think a couple of weeks ago. We will include that on the website as a resource to link to that paper. And that is actually research done by Dr. Steinman on many thousands of patients by doing interviews and on attitudes around deprescribing, particularly in people with families with the cognitive impairment, residents with cognitive impairment. And they found out that as the number of pills goes above 5, there is significant agreement by the family that actually not every pill is very beneficial, right? So, and most of our residents are definitely taking more than 5 pills. So I think the families are smart, right? They also are questioning that, hey, does my mom really need that many pills? But what Chrissy said is very important, that you have to build that trust. You have to get them prepared before you push, stopping the pills. You need to, we all know that we have to build that bond, saying that I really care about your mom, right? And then all those conversations become easy, right? If the first interaction is about let's stop pills, then it's going to be really, really hard. So.
Yeah, Jennifer Prukowski, our project leader, also, and she has studied this as well, and she just wrote in the chat, with families consider first gauging their willingness to deprescribe by the following question: do you feel your loved one is on one too many medications, not enough, or just right amount? So that's maybe a conversation starter during a care conference. I'm just fascinated that I would always think as a physician, it is really my job to talk to the families and have that whole long discussion. And of course, I have so many other things to do, and I'm so pulled in so many different directions that I sometimes don't have the time to do that, and that lacks then. And I'm just so fascinated, Dr. Hawkins, that you were able to engage the nurse practitioner, and then Chrissy is able to engage the nurses, the charge nurses, and it works. And I think the beauty about this is that not only do you engage them, you teach them. So, so they have a stake in the game, and then the nurses are probably really good at teaching the family members. That is part of their core competencies, really. That the interaction with the family and the family teaching and all of that. That you were able to harness that. I think that is a beautiful example of delegating in the right way. So I think this is really fantastic. All right.
Let's go to the next slide then.
Yeah.
Back to our geriatric fellows who were on their team. The fellow that worked on the Anticholinergic project, her process was to call and meet with each resident and the power of attorney to explain the risk benefit of the anticholinergic medications that their resident family member was on. Unfortunately, even though they had dry mouths and constipation and were still incontinent, they did not want to stop their oxybutynin. It was pretty discouraging for our fellow. And she decided she didn't think she could do a research project when nobody was willing to participate. So she went on and worked on a different project. But as we look back in our data, our anticholinergic usage rate dropped from 33% from last spring to 7% of our residents. And that all happened right in November when she was doing all those conversations with people. So something worked. It may not have been that first conversation, but it might be afterwards, as that dry mouth and constipation and incontinence continues, people have another thought. Go on to the next, please. The other project was on the sliding scale insulin process, and our fellow just followed the webinar discussion of how to go about deprescribing sliding scale insulin, pretty much word for word. And she reduced our sliding scale insulin usage from 9% of our residents to 2% of our residents.
Wow.
Last week, she presented a poster at the AMDA annual conference, and they won the Quality Improvement Award.
That's fantastic. That's awesome. 2% insulin, sliding scale insulin, that's actually really good. I wish that I had such low usage of sliding scale insulin. It's wonderful.
Yeah, I agree. If we can get a copy of that app poster, we would love to show that and share that with everyone.
Okay.
Yes.
So our next slide is just our data on the areas that we have actively worked on. So we started last spring with 160 long-term residents. We're down to 111 now. But in the anticholinergic, as I said, we were at 33% usage. We're down to 7. Benzos, we did this January bring in our nurse practitioner from the psychiatry team to work with us on that, because she's often the one that's prescribing that. And she's very engaged with us. And we've seen our our benzo rates drop from 23% to 7%. The sliding scale insulin, our PPIs were not as robust drop, but 45% down to 35%. And then our multiple vitamins dropped from 44% to 28%. Next slide.
Well, can we kind of give you all, I almost feel like I want to give you a slow clap or something. I think this is actually, I think, very, very nice results. Yeah, next time we'll have to organize like a slow clap. But I mean, these are actually very, everybody just do a regular clap. I think, first of all, your process. First of all, you tell people why. Right? You give them the tools, you have a process, you engage your team, and then you get the data. And tell me how you got, and you really gauge them against where you want to go. And so you have the success. And one of the big successes was the poster win. But I'm sure you as a team, how did you as a team feel about it when you were able to analyze those data and see how well you had done? What did it do for you, and what did you learn?
Chrissy, you want to answer that?
Yeah, Chrissy, I want to hear from you.
I'm proud of Dr. Hawkins for pushing this initiative so hard in such trying times that we've had. And I just think it's phenomenal, because it's not only great for our residents, but it's great for our floor staff that has been struggling, so short-staffed, less medications, it saves time. So definitely during such a challenging time, this is something that we can all be really happy about.
Yeah, and guys, if you the reactions on Zoom, there's actually confetti, you can clap, there's hearts. So be generous, because Cheryl and Chrissy deserve much of it.
Yeah. And did you staff actually feel that there was less work in the end? Did they say, wow, I can feel that I don't have like, a full cup of pills that I have to dispense or have to administer every 3 hours or whatever? I mean, we can get into pretty crazy administration routine.
Yeah, I don't know that we've shared all this data until we've accumulated it today to the broad facility. We've shared it at our morning meeting with all our division leadership, and success. And I think it's an upper. It's something to help celebrate in all this time of things going
Absolutely.
so hard. And I'm just really proud of everybody who's participated in this. It was invigorating.
Yeah, great. So I'd love to hear what your frontline staff thinks about it, and what feedback they have for you and for all the work that they put in. All right.
So lessons learned. Work with the team that you have. I showed you just how difficult our situation was in terms of staffing challenges, leadership challenges. Everybody focused on COVID and survey and all that has been on top of everybody's plate. You will need stakeholders, obviously, from the facility, but to just get started, if you've got a pharmacist who's willing to help you look at your meds, start with that. Start with a family member who's engaged and would be a champion. Maybe a resident. If you're in AL, you may have somebody who's willing to be your representative from the patient side. The stakeholders that you need include the residents and the families, and then your facility leadership and your frontline staff. I think how do you bring them all in is a question to brainstorm on, because it's different for the different groups. The families, we knew we needed to have conversation with them before we just broached the question at the care conference. We needed to have them understand we were working on this and why it was helpful, and some of the data about improved outcomes. I've been impressed with how small changes add up. I mean, these kind of percentage drops, they're, it's 5 or 6 persons that we've cut medicine down in each category, but that makes a difference. And in the big picture, we can be proud of the changes that have occurred. I think we've learned the hard way that you don't give up, approach a problem again from a different perspective, or just watch what you've done, give it time to declare itself, as with our anticholinergic project. I'm sorry, Arif.
No, sorry, I intruded. I just see the word sustainability there, which is such an important thing. And then the other word I see there is project. So I have a couple of comments on that. Number one is that, and I'm pretty sure it happened, but I just want to highlight for other people who are on the call, is that, number one, this project like this is not a project, right? You're building a whole new culture, which needs to last, right? I mean, this is how care should be delivered. I mean, really, you entered into a new era or a new culture of care in your building. And this is not a project. This is how care should be delivered. We should be so careful on how pills are managed in our buildings. And it should always be one of the top 3 priorities among the 30 things which should be top 3. It should be one of them, right? So I think that's number one. And number two, I'm pretty sure, I'm hopeful that approaches like this also results in us being very cognizant when we are writing prescriptions, right? It's not just about cutting prescriptions, but when we write them, we need to be very observant of how long are we writing them for? Are we putting frameworks of a week, 2 weeks, 3 weeks? How quickly are we coming back to reassess the benefit or no benefit from pills? So I think a culture like you're developing also comes up with other things which need to be a part of that culture so that this problem doesn't even exist in the first place. So any comments on some of those things?
Well, I think the part that we'll see sustainable is the care conference side of things, because it is always something that's going to occur. Now, we had started doing this a few years ago, way before COVID and all, but with lots of change in leadership and challenges. If you don't have all your unit managers, they're picking up somebody else's duty, and then they don't know about this. But I think having a champion in the facility like Chrissy as our ADON, she's looking out for our quality, and we'll pass it on to the different care managers as they come and go. That's where I see it's probably going to be most sustainable. These little projects of the insulin reduction and anticholinergics, we will need to keep an eye on and be reviewing. But now our staff knows, okay, if they're still incontinent, then why are we giving this? Let's raise that question to the provider or to the charge nurse who's going to do the care conference and bring that to everybody's attention.
And I have one more question of Chrissy, because I usually do not get to talk to very energized ADOMs like Chrissy. So I really want to ask this question. Chrissy, what do you think could be the role of a CNA in this initiative? I didn't hear much about it, but I'm sure you have a perspective on how the CNAs could help further this impact of approach like this. Any thoughts on that, or have you seen any things so far from that end?
I haven't. I'd have to give some thought on that. Just with them not being involved with the medication at all, but they are a trusted part of to the family and to the patients. So there could be a role there.
Well, I definitely am aware in my past, as past experiences, that a CNA kind of propagated a thought on a sleeping pill, or a recommendation actually came from a CNA to the family, and the family asked the nurse. And so I know that there is conversation that happens that could actually work against or work in the favor of this approach also. So I think, how can we tune in our frontline CNA so they can actually become active partners in helping us, so that they can become teachers and educators and give awareness to the family that not all pills are great. And not all pills are bad, right? Rather than pills are awesome, right? I mean, in the culture we live in right now, the more pills, the more you care, right? I mean, that's kind of the default in our culture. Maybe CNAs can help us kind of make that kind of neutral, if you will.
Mm-hmm. I learned at the AMDA conference about the value of the CNA and bringing them in to our team. And we're going to be working on a project to do just that. And so hopefully we'll get input, and they know there's a way that they can share information that they come up with to the team, that we can get that to the right person.
I thank you, Ara, for bringing this up. And yes, part of the AMDA conference, and a fairly prominent part, was the role of our CNA team members. And I know you gave, Ara, you gave a session on that. And during the session, Lori Porter, who has the CNA Professional Society, said, involve your CNA in rounding. Now, they won't always have time to come with you to the bedside, but I usually ask the CNA how the patients are doing, because I know that they actually know how the patients are doing. And are they eating? I always ask it, are they eating okay? Is there any change? But what about asking an extra question? How do they do with their pills? Or are they sleeping okay? Or, things like that, because they may be able to tell you, she hates that pill, or, she always gets a stomach ache after she eats that. She has that multivitamin or whatever. I think they could give you can just ask and then stop and see what they can offer. And also say, yeah, we're thinking of taking this away because that's not, and then teaching them why you deprescribe or optimize, but also asking them our clinical information. I think that would be a very good way of involving the CNAs. It's just part of the general rounding. So I think carrying what you said in your session and Lori Porter said in your session at AMDA, carrying that over to D2D, and can be used in many ways. So.
But Cheryl, Margot has a question. Margot, do you want to unmute and ask your question?
Sure. I just wondered if after you discontinued some of the medications, if there were any negative behaviors that showed up either for the first time or returned with your folks with dementia.
Like on the benzos, is that what you're talking about?
Or any antipsychotic that you might have used, that they might have been on at one time.
Chrissy,
I haven't
heard anything? I haven't.
Nope, I haven't heard anything or seen any negative behaviors. We talk about behavior every day. So,
and there are studies on that actually, which show that there may be a 15% increase in behaviors. If you're specifically talking about antipsychotic, of course, in your building very appropriately, it was beyond antipsychotic, it was everything you guys addressed. But yeah, Margot makes a good point. You will, I mean, it's not one and done thing, right? I mean, a lot of polypharmacy management optimization always is going back and seeing if there's any relapse of any of the symptoms, and then you can come up back with a smaller dose or whatever. So you absolutely have to monitor for that.
Well, then at least you have current data that says to you, this didn't work with this particular person. That doesn't mean it won't work with anybody else. It just didn't work with this person. But I have to give kudos to the nursing department for taking the lead along with Dr. Hawkins to get this done. And I don't think that any kind of change like this can actually be accomplished without the involvement and cooperation of the nursing department. If you don't have nursing department buy-in, your project will not go forward. Are you considering making this a model for everyone?
A model?
You mean, who are you asking, Dr. Quincy?
Chrissy or Dr. Hawkins?
Well, this is how we now take care of all of our residents. The care conference for subacute care is more frequent, or because they're only there short times, but and I don't know that they like to change a whole lot of the medicines, especially some long-term things that if the patient's only going to be there 2 to 3 weeks. But we do it for all our long-term patients. They have a care conference, so every one of them gets reviewed, and that's every 90 days that we go through those folks.
I'm sorry, actually, I wasn't clear. I meant the drive to de-prescribe. Can we possibly put this together as a model for other long-term care facilities?
Absolutely, I would encourage, actually, I think definitely we have this webinar, and I think that is definitely a model of implementation. So what we are all about here is implementation. We all know how de-prescribing is bad, but what we are all about here is teaching each other how to best implement. And we were immediately struck by this remark, and we will hope, we have some plans on writing this up in Caring for the Ages, so that it is available and for all of you as a reference as well, and that it is out there. So so I think that is a very, very good way to implement. I would like to know whether you have any other questions, or anybody from the audience. Do you have any other questions or any other remarks or any successes or problems? Dr. Kaplan, hi Bob, states here, we need to remind our PCPs, NPs, and PAs to reinforce D2D progress with residents and family during their regulatory rounds. So I take that to mean, Dr. Kaplan, that you say, so hey, we were really successful in de-prescribing the sleeping pill, and your mother is sleeping fine and she's more awake in the morning, or something like that. Or, you know, she was on a ton of medications and now she's doing fine with only half of them, or something. Is that what you mean?
Yeah, exactly. Or if we know by speaking with patient's nurse or CNAs, et cetera, that the family or the resident was resistant to a particular de-prescribing of one particular medication, and we might be able to answer questions and turn that around into a positive, you know, into positive progress.
Okay, so getting that feedback from all the team members.
Right.
Yeah. Yeah, good point.
And yeah, you know, and then successes inspire others who may be resistant early on. You know, hearing successes, they can actually kind of change their perspective. So I think sharing good stories and successes with everyone on team and resistant families, I think is the right thing to do.
Any other?
Sorry, Sabina, I was going to say we are right at time. I just want to mention that.
Yes. Okay. So I think we want to again thank our participants, Cheryl and Chrissy, for inspiring us today. I think this model of utilizing care conferences and utilizing all team members is something that you can do now. You can talk with your staff right now to see whether you would like to implement that. The other thing you can do now is download, we will give you access to Dr. Hawkins' family member letter. We have one too. This one that she has is very much to the point. And so you can do that as well. So
and it will be, Sabina, wouldn't it be cool to bring Dr. Hawkins and Chrissy back in a few months to just hear about their sustainability, right? So.
Oh yeah, we'll follow up with you. Yeah, so those two things I'd like you to think about moving forward. We will be, the Spearhead group, of which Dr. Hawkins and Chrissy were the first active participants, will have further opportunities to share their successes. And what's next for D2D on April 21st, which is our next teaching webinar, we will focus on what the White House wants. The White House, you all have seen the fact sheet from the president, and CMS will launch a new effort to identify problematic diagnosis. You know, that has made quite the headways, the diagnosis, and refocus efforts to continue to bring down the inappropriate use of antipsychotic medications. That will be our next topic on April 21st. And we have wonderful experts lined up for that. And then in May, we'll have a progress update with more Spearhead group members. So thank you, all of you, for joining us today. And I hope you got some good ideas and impulses to move forward. And congratulations to Dr. Hawkins and Chrissy for a wonderful result on their innovation in deep prescribing. Bye-bye.
Thank you.